All right, and now our next speaker is Dr. Karadal from the Albert Einstein College of Medicine, who will be presenting racial disparity in tumor microenvironment and outcomes in residual breast cancer treated with neoadjuvant therapy. Dr. Karadal?
Good afternoon, everyone. Thank you for the opportunity to present our work in here. Today, I'm going to talk about racial disparity in tumor microenvironment and outcomes in residual breast cancer treated with neoadjuvant chemotherapy. As we all know, majority of breast cancer-related deaths are caused by distant metastases. 5-year relative survival of distant metastasis is only 29%. And when we look at this percentage even closer, we are seeing there's racial disparity. White patients remain similar as 30%, but black patients' survival is only 20%. And overall, black patients with breast cancer have 40% higher death rates compared to white patients. Surprisingly, black race is associated with distant recurrence in ER-positive HER2-negative, but not in triple-negative or HER2-positive disease. 3 randomized adjuvant breast cancer trials show that black race is associated with increased risk of recurrence in ER-positive HER2-negative disease. In addition to adjuvant chemotherapy, we also found racial disparity in neoadjuvant chemotherapy setting. On the left, we are seeing distant recurrence-free survival in patients with residual disease after neoadjuvant chemotherapy, and black patients in blue have inferior survival compared to white patients in red. Black race is an independent prognostic risk factor in residual ER-positive disease, but not in ER-negative disease. So our main question is, what could cause racial disparity in residual ER-positive HER2-negative disease? Our hypothesis is racial disparity in distant recurrence-free survival in patients with residual ER-positive HER2-negative disease is due to an enhanced prometastatic response after neoadjuvant chemotherapy in black compared to white women. Research objectives are determine if prometastatic changes in residual cancer after neoadjuvant chemotherapy are associated with inferior outcome, and determine if there is racial disparity in prometastatic changes in residual cancer after neoadjuvant chemotherapy. Racial disparity in outcome might be related to differences in prometastatic tumor microenvironment. When we compare tumor microenvironment in African American patients and European American patients, there are differences in immune cells, stromal cells, and cytokines. I'm mostly interested in macrophages and microvascular density because these are components of TMAM doorways. What are TMAM doorways? It's tumor microenvironment of metastasis doorways, which are portals for cancer cell dissemination. It's composed of 3 different cell types: tumor cell, macrophage, and endothelial cell. The tight and direct interaction of these 3 cells results with transient vascular openings, and this helps tumor cell intravasate and disseminate. We can visualize these events by intravital imaging in our lab. Here we are seeing mouse primary tumor cells in green, macrophage in blue, and vasculature in red. We are injecting high molecular weight, red fluorescent tag dye into vasculature. This is an inactive TMAM doorway, and dye remains in the vasculature. But in here, in the same area, we are seeing there's transient vascular opening and the dye leaks out to tissue. And I want to point out that the interaction of these 3 cells is stable. And we can see some tumor cells and macrophages intravasated. We can also use these images and do 3D reconstruction of the cells, and we can see the interaction of these 3 cells in here. 3 of the case control studies show that TMAM doorway score is associated with increased risk of metastasis, especially in ER-positive HER2-negative disease. And neoadjuvant chemotherapy may induce prometastatic changes in tumor microenvironment, including TMAM doorways. Mice treated with paclitaxel had increased TMAM doorway score and increased disseminated tumor cells in the lung. In a small cohort of breast cancer patients, when we compare TMAM doorway score before and after neoadjuvant chemotherapy, TMAM doorway score increases after neoadjuvant chemotherapy. In this study, our study design is prospective, retrospective, multi-institutional case control study. Patient samples are collected from New York Pathology Oncology Group institutions, and we follow DREAMmark guidelines. Our inclusion criteria are unilateral invasive ductal breast cancer diagnosed between 2004 to 2014, residual disease minimum 5 mm, HER2 negative disease. Exclusion criteria are history of prior cancer, male gender, and metastatic disease at time of diagnosis. Race is self-identified. We have 96 Black patients, 43 of them ER-positive HER2 negative, 37 triple negative disease. We have 87 white patients, 50 of them ER-positive HER2 negative, and 22 triple negative disease. Here I'm showing only significant patient characteristics. Black patients compared to white patients had higher distant recurrence. They tend to treat it with mastectomy over breast conserving therapy, and they had higher grade. We also looked at age, time to distant recurrence, tumor stage, lymph node status, subtype, and neoadjuvant chemotherapy regimen, which were similar between patients. We stained residual disease with TMAM doorway triple IHC staining. We used PanMINA for tumor cell marker, CD31 as endothelial cell marker, and CD68 as macrophage marker. On the right, we can see pink tumor cells, blue vasculature, brown macrophages. And the analysis of TMAM doorway, endothelial cells, and macrophages are done by automated analysis. First, we compare ER-positive HER2 negative and triple negative breast cancer. We saw that in triple negative breast cancer, we have higher TMAM doorways, higher macrophages, but there is no difference in microvascular density. This finding might be one of the mechanisms of early recurrence in triple negative breast cancer. After looking at the subtypes, we looked at same markers in aspect of racial disparity. And Black patients compared to white patients had higher TMAM doorway score when we combined all the patients and in ER-positive HER2 negative disease, but we didn't see any difference in triple negative breast cancer. This finding may explain racial disparity in ER-positive HER2 negative disease. Macrophage density followed similar trend as TMAM doorway score. In Black patients, there's higher macrophages in all subtypes and ER-positive HER2 negative disease. We didn't see any difference in microvascular density. Importantly, patients with high TMAM doorway score in blue had inferior distant recurrence-free survival compared to patients with mid-low score when we combine all patients. And in ER-positive HER2 negative disease, even the p-value is 0.059, we can still see the separation between high and mid-low score, which we didn't see in triple negative breast cancer. Only high TMAM doorway score was associated with inferior distant recurrence-free survival, but not high macrophage or microvascular density, which showing us that the interaction of these three cells are really important for distant recurrence, more important than individual components of the doorway. High TMAM doorway score is an independent prognostic risk factor in the entire cohort. And as you would expect, other independent risk factors were high tumor stage, positive lymph node status, high grade, and triple negative breast cancer. In ER-positive HER2 negative subtypes, TMAM doorway score trended towards being an independent prognostic risk factor with p-value 0.06. As a summary, in ER-positive HER2 negative residual breast cancer after neoadjuvant chemotherapy, we saw that in Black patients there is higher macrophages and more TMAM doorways. Our conclusions are high TMAM doorway score is an independent prognostic risk factor of inferior survival in patients with residual cancer after neoadjuvant chemotherapy. And racial disparity in outcome may be due to a more pronounced prometastatic tumor microenvironment, especially increased TMAM doorway density in Black compared to white patients with residual ER-positive HER2 negative cancer. And in clinic, when we consider prognostic factors, for example, established tumor size or lymph node status for local spread, in this study we are proposing we can include TMAM doorway score for distant spread. Thank you so much for listening, and I want to thank you, my mentor and supervisor of this project, Dr. Maya Oktay, and Dr. Gina Kim, who was working on this project before I joined the lab, and all of our collaborators and funding. Thank you.
Thank you, Dr. Karadal, for that excellent presentation. And now we'll look to the audience for questions. Microphone 3, please.
Yes. Congratulations, very nice talk.
Thank you.
But I was wondering, have you checked the body mass index in your black people? Because adipose tissue display a strong capability to recruit macrophage.
Yeah, actually, this is a really good question. Unfortunately, we didn't include BMI in this study, but it's really important to include that. Thank you.
But it's an interesting aspect.
Yes.
Thank you.
Thank you.
Yes, microphone 3 again.
Very nice presentation, Priyanka Sharma from University of Kansas. Did you look at any relationship with the score and the amount of residual disease by either RCB or some other criteria?
No, actually, all of our patients had minimum 5 millimeter residual disease, and they had like similar residual disease score. So we tried to normalize it actually. So we didn't like have like differences in that aspect.
I might ask a question that's coming from our virtual audience. If you stratify the hormone receptor positive tumours into luminal A and luminal B, are the differences in the TMM doorway numbers between black and white patients maintained?
That's a good point actually. We haven't looked at luminal A, luminal B, or basal cell type. We're usually interested in ER positive, HER2 negative, and triple negative breast cancer. But it's a good point to like stratify that into luminal A and B and look at that. Thank you.
I might ask a question, if I can. I feel like this is an incredibly valuable set of tissues or data set that you have. And we've seen other work published this year looking at potentially other differences in the tumour immune microenvironment that exist between people of different ethnicity or racial background. So have you looked beyond the TMM doorway at the tumour microenvironment in the residual tumour? And are there any other interesting changes there that you think could be contributing to the results?
Actually, there's one part of this study that I haven't shown in this presentation, which is cancer stem cells. We know that from published study that TMM doorways, especially interaction between macrophages and tumor cells, increases stemness of the tumor cells, but we didn't see any racial disparity in that aspect. There was no difference in cancer stem cells, but mainly we are interested in TMM doorways in our lab.
Thank you very much. I think that's all the time we have for questions, so we might move on to the next part of our session, which is going to be a discussion. Thank you.